alaikum and good afternoon to everybody. This is Dr. Mohammed Kurdi. I'm the president of the Saudi Arabian Interventional Cardiovascular Society and member of the Gulf Interventional Society. It's my pleasure today to moderate with a group of eminent interventional cardiologists at the region, at the Gulf, and in France to discuss a very important and a very interesting topic that we've been talking about for ages and ages. And every time and every presentation, we learn something new. Today, we have our French colleagues from the Cardiovascular Institute, Cardiovascular
On peut faire demain, quoi. Moi, de toute façon, je suis là demain.
Hello, Dr. Antoinette. All right. So we have an interesting program. This is part of the Master Intervention class curriculum for the GIS 2021. This is a program that in the era of COVID and an era of the lockdown, and now after, hopefully as the COVID is hopefully weaning off, we are continuing to deliver the top knowledge and the top discussion with the top speakers. It's my pleasure to introduce today the first talk. And the first talk is by Dr. Lefebvre-Thierry. He's head of interventional cardiology in Cardiovascular Institute Paris-Sud in France. Dr. Thierry, he will discuss with us his first talk is titled, What should we know about bifurcation lesion? Please, Dr. Thierry, you can take the microphone and start.
Thank you very much, Mohammed. It's really a pleasure to be with you and to have the opportunity to share experience in bifurcation lesions. So I start with the talk, and the aim of this talk is to give some flavor about what we should know about bifurcation lesions when we are treating this kind of lesion. So the main reason is that we need to have a standardized approach in order to have something which is reproducible during the procedure with a high rate of success, a low risk of complication, and also a good long-term follow-up. And long-term follow-up is also very important in this field. So what we need to know, first, the relationship between the structure of the coronary arteries and the function toward the myocardial infarction. I think it's very important to understand the field of bifurcation. The role of proximal optimization technique, which is very important, whatever the technique we use. Proximal versus distal strut, I will not go into much details. The rheology is also important in terms of long-term outcome. The role of carina shifting, which is something which is underestimated, and it is very important. The side branch relevance, because sometimes there is not relevant branches that you just should protect and no more. How to do a KISS, and at the end, some general rules about bifurcation lesions. So let's start with the relationship between structure and function. So the coronary tree is like a tree with big branches, small branches, and the main reason is that it delivers a flow to myocardium. And there is a clear relationship between the main branches and side branches. It was studied many times, and the simple rule is that when you have a side branch, the ratio between the main branch and main branch proximal and main branch distal and side branch is 0.6078. So a very simple ratio, which is very helpful when you have to understand what is the size of the proximal main branch, or what is the size of the distal one, or the side branch when you don't know one of the three branches. So this is bifurcation. So proximal main branch, distal main branch, and side branch. The original law was the Murray's law, which is relatively complex. It was more recently complexified by Hugo Cassab. But Gérard Finet, a French doctor in Lyon, showed that this relationship very simple. The proximal main branch is the addition of the distal main branch, side branch, multiplied by 0.678. So this is very simple, but very useful in daily practice. So it means that we have 3 diameters. And this is very important because if we do not respect this rule of 3 diameters, for example, we stent the bifurcation with a stent according to the proximal reference, we may push the carina and close the side branch. On the opposite, if you stent the bifurcation with a stent according to distal main branch reference, then you have area of malapposition. So this is why POT is so important, so proximal optimization technique. It was nicely demonstrated by Olivier Darmon many years ago, and this is after deployment of a stent according to distal reference, and you can clearly see that there is areas of malapposition, and of course many options to go through the strut in the side branch. If you do proximal optimization technique, like you can see on the right part of the panel, then you have a good apposition of the stent at the level of the bifurcation, proximal to the carina, and also proximal at the level of the proximal stent. So then you have not a lot of possibility to go through the strut toward the side branch. And what we try to do is to go through the distal one. So this is an example. After doing proximal optimization technique, you go through a distal strut, and then you have this kind of appearance, which looks like really a dedicated stent for bifurcation lesions. If you go through the distal strut, you have this kind of result. So now we have clinical data showing that proximal optimization technique is very important. This is the ELT master registry, which was published recently in Neurointervention. And you can see that if you don't do a proximal optimization technique, the outcome is not very good as compared to a good proximal optimization technique in green. And this is true whatever the lesion, so left main, not left main, etc. If you look into details, when you use a one stent technique, you can see clearly that when you do proximal optimization technique, you have less target vessel MI, less TLR, less TLF, and also less risk of stent thrombosis. So 0% when you do proximal optimization technique versus 1.1. And this is clearly significant. The problem is that proximal optimization technique is done in very few cases. In this study, only 34% of patients had proximal optimization technique. This is an example with the 2-stent technique, and you can see again a big trend in favor of using proximal optimization technique. But again, even with 2-stent technique, POT was done only in 42% of cases. So it's really underused. And this is very important because whatever the technique you use, you can see that you have to do a POT when you do provisional, you have to do POT when you do a tear tap, you have to do POT when you do kissing 3 times, and you have to do POT even when you do decay crush at least 3 times also. Now, what about proximal and distal strut? This is something that we learned many years ago in my center. When you go through a distal strut, you have this kind of deformation when you open the strut, which can be corrected by kissing balloon inflation. But you have also a nice scaffolding of the side branch osteum with the main branch stent. This was confirmed 10 years later by John Ormiston in New Zealand in the bench. Now, why we should open the strut? And this is data from Ronnie Matthew in India. He showed that at follow-up, you may have patients who come back later with a pseudo-restenosis, which is related to a colonization of struts by a neoendothelium. So this is an unopened strut in the circ after left main stenting crossover, and you can see clearly that there is something which looks like a restenosis, but it's just a neoendothelization of the stent strut which were not open. Rheology is also something very important, and you know clearly that in bifurcation you have an area of low shear stress opposite to the carena, which promote atheroma opposite to the carena in both branches. So this is exactly what we have at the level of the bifurcation. What is important is that you have high shear stress at the level of the carena, and then that's why the need for stenting at this level is not important. Carena shifting is something which was clearly shown by Dr. Koo in Korea, showing that when you stent the bifurcation with a stent according to distal reference, you push the carena and you may close the side branch. Of course, if you do kissing ball inflation, you reshape the bifurcation and you reopen the side branch by putting the carena in the middle of the bifurcation. What we learned also by Dr. Koo is that we are overestimating side branch lesions. So this is examples. Of course, you may say that all these lesions are significant, but when you do FFR, many of them are not significant. You can see this one 0.93, this one 0.84. So before stenting the side branch, I think we should really be sure that they are a source of ischemia and also that they are relevant. You can see clearly in this paper of Koo that only few patients have a functionally significant lesion, despite the fact that by QCA, they have a lesion more than 75%. So side branch relevance is also something very important, and we learned that from Ashamovich many years ago. If you have less than 10% of ischemia, the benefit of revascularization is not significant, and even opposite. So we should assess the side branch lesion because the majority of them represent less than 10% of myocardium perfusion. And this is a study by Kim showing that in many cases, looking at the side branches, for example, diagonal branch, you can see that this first diagonal branch, in the majority of cases, are not relevant. Only a few of them are relevant, but the majority not relevant. The worst with diagonal 2, the same with obtuse marginal. So very important to understand that there is branches that you don't want to lose, but they are not relevant in terms of long-term outcome and in terms of ischemia. Now, how to do a kiss? I think it's very important because kissing ball inflation is recommended at least for true bifurcation lesion treated with 2 stents. It's controversial when you use only 1 stent. But you can see that in many studies, in this study from Song, in COBIS-1, you can see that if you do a final kiss, you have a better outcome. This is also for 1 stent approach in the same registry, and you can see clearly that if you do in COBIS-2, if you do a kissing ball inflation at the end of the procedure, they decrease by 50% the risk of MACE. Of course, it's still controversial, and the main reason is that there is a very clear recommendation on how to do a good kiss. So of course, you have to do a pot before in order to be sure that you will go through a distal thread. You should go through a distal thread when you open the side branch. It's true for all techniques except for DCAC rush when you have to go through a proximal one. It's very important also to use short non-compliant balloon, at least for the side branch, and to do kiss in the polygon of confluence in order not to make too much deformation of the stent. Long inflation, and this is usual whatever the stent you use. Sequential inflation, so side branch first, preferable, and simultaneous deflation. Last thing, simple rules in the treatment of bifurcation lesion. So it's quite a summary of this presentation. So very important to understand that there is a fractal law, and we should respect the fractal law when we stent the bifurcation. side branch needs attention when they are functionally significant. So very important to assess the significance of the side branch. Limit the number of stents. We know that the more stents you use, the high risk of MACE. And a single layer of stent is better when deployed and when opposed. So thank you very much for your attention.
Thank you very much, Dr. Terry. It's very interesting and comprehensive review. I think we can lead a little bit of discussion and we'll see if we have any questions. I'm going to actually start with a question where I would say, what's in your mind the acceptable difference between sizing for the distal vessel or distal bifurcation versus the proximal? When do you think this is going to be too much of discrepancy that I need to use a different strategy?
Yeah, I think it's a good point, especially for left main stenting. For example, you may have a 3.0 LAD and a 4.5 or 5.0 left main. So a big discrepancy. But we know that if we want to have a good scaffolding of the left main, we need a 3.5 stent. So what we do in our lab is that we use a 3.5 to respect the fractal law at low pressure. So for example, we deploy the stent at 8 or 9 atmosphere, and then we do proximal optimization with a 4.5 or 5.0 in the left main, and we do a kiss at the end. I think it's very important to have also in mind that in the majority of cases, the 2.25, the 2.5, and the 3.0 stents are the same, exactly the same. So the only difference is the balloon size. So if you use a 3.0, you are comfortable to do proximal optimization with 3.5 or even for 4. But very important to remember that this 3.0 is also a 2.25.
Do you think the type of the stent and the structure of the stent will make a difference in such cases?
Yes, absolutely. So today, I think the majority of stents gave a very good scaffolding. I think for left main, some stents are better than others, especially in terms of strength. The Megatron, for example, is really a very good stent for left main, especially when you have calcification and you need a good strain.
And the angulation between the main vessel and the side branch, what will be your acceptable angle that you still deploy choosing the bigger branch or the bigger side branch? How would you set your strategy when the angle is too acute or too narrow?
I think it's a very good point. So this was studied in Japan, in the bench, not in the patient, but in the bench. And they showed that when you have to use 2 stents, the best approach in terms of final result in the bench is to stent toward the circ, not toward the LAD. Because if you put the stent toward the circ, then you do proximal optimization technique and you have a very nice opening of the struts toward the LAD. So I think it can be very useful to do that. On the opposite, it depends also on the difficulty to access one of the 2 branches. So usually we prefer to stent toward the difficult branch and not the easy branch in order to simplify the procedure.
I don't know if any of the panelists have any questions.
But if you allow me, how would you deal with an ostial side branch disease sparing the main vessel? It's a dilemma when we get a large diagonal, for example, or an ostial LAD or an ostial circ, and the main branch is normal, or Medina 001. How do you deal with it?
Yeah, it's a good question. So we had a lot of questions many years ago about that. And finally, we decide to do what we call inverted provisional. So we stent from LAD to diagonal. Of course, if the diagonal is relevant, if there is ischemia despite optimal medical treatment. But we do that. So stand from LAD to diagonal, do proximal optimization technique, open the strut, and do a kiss. And we have a long-term follow-up of this patient, which is very good. So of course, sometimes you may need to use a second stent, but it's very unusual. And compared to other techniques, like putting the stent right at the ostium, or this kind of technique is not working. So that's why we moved to this approach. And it's the same for left main. So if ostial circ, for example, we do exactly the same. So left main to circ, proximal optimization technique, kissing bone inflation.
And how often do you use imaging for non-left main bifurcation, considering the cost?
Yeah, so in our lab, we don't use a lot of imaging. We start to do it. So when we start to do left main, we were systematically using intracoronary imaging. But with experience, we decrease the use of intracoronary imaging for the same reason as you said. So it's very costly, it's not reimbursed. And we learn doing intracoronary imaging at the beginning. We learn which kind of mistake we can do, and I think today we are able to avoid these mistakes. But if there is something which is not clear during the procedure, we do intracoronary imaging.
Thank you.
Great. I think we are actually on time. So if there is no other questions, we can go to the next session.
So good evening, everybody. My name is Mohammed Al-Mukhaini. I'm interventional cardiologist from the National Heart Center in Oman. I'm going to introduce Dr. Philip Garou, who's the interventional cardiologist at the Cardiovascular Institute of Paris, SAD. He's going to talk about an interesting topic, which is actually how to manage difficulty in side branch access, which is a difficulty we face all during our daily experience in the cath lab when we do a bifurcating lesion. So, Dr. Philip, can go ahead with your presentation.
Thank you very much. I'm going to share my screen now. Can you see my slides?
Yeah.
Yes.
So thank you very much. How to deal with difficult anatomies and side branch access. What is the first question that rises? What is the difficult bifurcation anatomy? And we know that we have some possible difficulties like wide angle between the main and side branch, which is more than 90 degrees. We may also have complex lesion within the bifurcation lesion, meaning long lesions, calcifications, aneurysm. And we may also have tortuosities of the lesion proximal to the bifurcation, and all of that would make the bifurcation treatment difficult. So some general rules to facilitate wiring. First, I would say it's like normal to think about that, but we have to think about that prior to the attempt. We have to look carefully at the angio and have some different plan. Plan A, if everything is running good. Plan B or C or D, I don't know if things are going more difficult than we think. And second point is that it's very important to select one or two optimal projections with the bigger angle to treat the bifurcation. Second very important point is to have a very good backup support, avoiding in general Judkins catheters and taking rather EBU, Amplatz left or 3D right guiding catheters for the right. The first technique is to use the individual's wire shape. These are some examples with a single bend short tip, single bend long tip. Sometimes smooth bend could be useful, or double bend in some cases. It's done and chosen according to the bifurcation anatomy, starting with the workhorse wire, and use a torquer to have better control of the wire. This is an example of an individual wire shape. You see that it looks easy like that, but of course, it's not enough when dealing with complex bifurcation anatomies. The pullback technique has been developed some years ago and described here by Buzotta. The technique is to push the wire in the remote vessel, and while pulling back the vessel, the tip of the wire is engaging in the stenosed vessel. You see the pullback technique here. And derived from this technique is the long U-shape technique. This technique is done while having a U shape of the wire. You see on the A panel, it's a long U shape, and you may push the wire with this shape in the remote vessel. And you see that when you pull back gently the wire, it may engage into the side branch in this case, which is narrowed, and it may go in this vessel by pulling back the wire. This is an example of a long U-shaped technique. You can see here, this is the lady, and the wire is pushed in the diagonal, and while pulling back the wire on the right panel, you see that it engages the LAD, and this is easy to do. It's non-complex, not costly, and it's very, very useful in some very complex osteal lesion, like in this case. Of course, anytime you have to think about the procedure, change the guiding catheter if it's not going well with bad support, reshape the wire, the tip, consider some new wires, change projection, and adapt your fluoro quality in terms of frames or dose. And of course, working as team, you have to ask your colleagues' opinion and not do this lonely on your side. Be reactive is increasing the chance of success in complex cases. This is the concept of wire escalation. You see here some different wires, tip and strands. You see the workhorse wire we're using in complex lesion with the fielder in many cases, but we have to think about wire escalation with XT or sometimes cyan or black wires. This is the very important microcatheters are used for the bifurcation lesions. You see here, we may have some steerable like Venture and more recently the curved supercross microcatheter. You see here the different angles we may have, 45, 90, or 120 degrees. These microcatheters increase wire and tip control and make a wire exchange before or after crossing very easy. You see on the right panel that you may go with the microcatheter in the remote vessel, and then you may pull back to the bifurcation, torque, and go gently with the wire across the lesion. This is an example of a very diseased osteal diagonal. You see that there is an aneurysm at the place of the bifurcation lesion in LAD, and you see here on the right panel that the wire is going with a loop in the aneurysm to the diagonal. It was cyan black used for this, and it was really, really difficult to do without this technique. And then you may go with a microcatheter on the cyan black, and you see on the left panel, it's going through the loop, and then you pull back the microcatheter very carefully, not to lose the wire, and you may correct the loop deformation as it's shown now, and then you may engage the diagonal with your wire, like it's done now. Other possibility is to use a dual lumen catheter. This is an example of a marginal lesion on the left panel. You see the osteal lesion of this huge marginal branch, and wires were going in the small branch up to the lesion. it was very difficult to engage despite the use of Sion, Fielder, and different strategies using different microcatheter and wires. And finally, with the use of a fine dual lumen catheter, you may engage the side branch as it's shown on the left panel using the side hole of the dual lumen catheter. And then you may treat this bifurcation with one stent, and as Thierry described the technique, a pot and optimize the lesion. And this is a huge marginal branch that was very difficult to do without this microcatheter. This is another example of a proximal LAD lesion. You see here this tight lesion of the ostium of the LAD with two huge branches, one LAD on the upper part and one first diagonal on the lower part. And the technique used here was a supercross microcatheter. The wire was advanced in the easiest branch, the lower branch, and then the microcatheter was pulled back and then gently controlled and placed in the upper branch, as it's shown in the left panel. You see here, it's positioned at the ostium of the LAD. And then when you are in front of the origin of the branch, you may advance your wire through the microcatheter as it's shown on the right panel now. You see here the microcatheter and the wire is gently advanced through this catheter in this branch that was very, very difficult to wire without this technique. This is the result after predilatation, one stent positioned from the left main to the LAD, two pots for LAD and for left main, and two kissing balloon inflation, LAD diagonal and LAD circumflex. Other option that we should consider, but it's a little bit dangerous option, is to predilate. In some cases, you see this one, very difficult to engage the circumflex because of the plaque, which is at the distal part of the left main, and because of the angle of the circumflex, which is very important. And you see that in some cases, you may think about predilating the lesion with small balloon and low inflation pressure to modify the plaque, which may help engage the side branch. You see here, this circumflex is a huge branch. It's a left dominant system. And with a small U-shaped technique, you may go to the LAD, and then by pulling back, you may engage the circumflex and go in this huge circumflex artery. This is the result after stenting left main to the circumflex, pot, and kissing balloon inflation LAD circumflex branch. Another example using rotablator, you see here this massively calcified distal left main lesion. You see that the ostium of the circumflex is really tight with a huge angle, and it was really difficult to cross this lesion to the circumflex. Here is the lesion and the angle, and we decided to do the rotablator from left main to LAD, which modified the plaque and the anatomy of the bifurcation, and then the circumflex was crossed using a U-shaped wire with venture catheter, as you see here, the theory, and then it's done here on this case with a venture catheter and a U-shape, and you see on the right panel that it was possible to cross this lesion, which was really tough to cross without these techniques. And there is the result with a stent from left main to circumflex and treatment of the distal left main bifurcation lesion. So this is the plan to treat the bifurcation according to the EBC consensus 2 years ago. And you see that difficult side branch access before stenting, you should try to use the pullback technique and reshape the wire tip. you should think about moving to a softer wire like Fielder C, Sion, or Pilot 50. Use microcatheter, dual lumen, supercross, and venture. Use, in some cases, U-shape or reverse wire technique. And the rotablator predilatation should be used at the last option, because it's there is a risk of closing the side branch, which make, because of the complex anatomy, the possibility to treat the lesion very difficult. And with using these techniques, you may have a good wiring success even in very complex anatomies. And my conclusion is that wiring the two branches of the bifurcation is crucial. Options in terms of wires, devices, strategies to deal with complex side branch access are numerous, and we should think about using these in very complex cases. And always think that when wiring the lesion is difficult, recrossing can be worse. So in some cases, we may consider treating this first branch first, especially if this branch is relevant and revascularizing a huge territory. Thank you for your attention.
Thank you very much, Dr. Philip. We'll have the time for discussion. I have one question. We all try to avoid jailing a hydrophilic wire in the side branch, but sometimes we cannot cross the side branch when we get difficulty except with a hydrophilic wire. So in case we jail the hydrophilic wire and difficult to retrieve it, what tricks you would advise us to do?
So you're right that sometimes only hydrophilic wire are crossing the lesions, and I think that the safer technique is to use a microcatheter, for example, to change the wire with a workhorse wire, and then you may jail this wire with the stent, and then you may do the bifurcation with a safe technique. But I agree that especially in some calcified vessels, using hydrophilic wires, you may have some problems with jailing with a stent, especially at high pressure. So it's very important to avoid this.
Any question from the audience?
What criteria do you use to protect the side branch?
So it's a very important question, and thank you for asking, because protecting the side branch does not always mean that you want to treat it. So I would say that the main criteria is I don't want to lose this branch, because I don't want patient to have pain or to have ST elevation or something like that. Even if I don't want to treat, I want to protect because I want to be sure that there will be no problem with this. If I want to treat this, of course, obviously we have to protect the branch, but we may protect some branches that are smaller than 2 millimeters, just to avoid to close it.
Thank you.
Any more questions? I don't see any questions from the audience. Any comments from?
Just a short comment about the last question. I think it's a very important question, because there is branches that you just want to protect because the risk of MI, but they are small. There could be a 1.8 millimeter or something like that. So at the end, you will not treat the branch except if you have occlusion or if you have ST segment modification. And there is branches which are relevant because they are representing more than 10% of the myocardium. So usually 2.25, 2.5. And this branch are protected also, but we treat them if they have a significant lesion at the end. And if there is a doubt, we may do FFR to be sure that the lesion that we see is really significant, creating ischemia.
That will lead me to another question. When you will use FFR, because sometimes angiographically, the side branch might mislead you. You might see a tight lesion on angiographically, but then you do physiological testing and you find that the FFR is 0.8 or 0.9. So when you will use the FFR when you assess a side branch after stenting. A side branch, whether you need to deal with it or just leave it as it is, especially if the patient is pain-free. When patient is having pain, then yes. But if patient is asymptomatic, but angiographically, you'll see the vessel is 90%. So I'll throw it to the
I think it's
group.
it's depending on the size of the vessel and on your first plan. I think it's important to keep the plan of what we wanted to do. If we want to do a provisional T-stenting, meaning that we want to treat the main branch and open the side, if you don't want to treat the side and you have a good result with some plaque on the ostium of the side branch, but you don't have any flow disturbance or any symptoms, as you said, or any ST elevation or something like that, you may leave the branch if it's not too big. If it's a huge branch and you want to treat with 2 stents technique, FFR is a good option. And as Thierry showed, Ku has done some very important study on this, showing that most of these angiographically tight lesions are functionally nothing. I think it's better to leave them like that.
Okay. Any more comments or questions? So I think thank you very much, Dr. Philip, and we'll move to the move on with our session, Dr. Hussein.
Thank you. We welcome Dr. Antoinette, who's a brilliant interventional cardiologist at Paris Cardiovascular Institute, and she will enlighten us about the special aspects of left main intervention. Welcome, Dr. Antoinette.
Thank you very much. So I'm going to talk a little bit just about the left main and specifics. So when we talk about the left main, well, what is so special about the left main? And certainly we have a large ischemic area to think about. So certainly very important when it comes to the consequences of losing a branch in bifurcation or trifurcation left main stenting. We're also dealing with very large vessels often, vessels up to 5.5, maybe 6 millimeters in the proximal part of the bifurcation. So it becomes very important in terms of being able to assess the size of the vessels and the size of the stent that's going to be needed in the distal main branch in order to achieve the proximal main branch diameters. We deal with bifurcations and often trifurcations with often 2 or 3 very important branches that subtend a very large area. We have to remember, of course, the fractal laws in bifurcation stenting, and the bigger the branches, the more important that the differences in diameters becomes. Calcifications, particularly in the left main, certainly more than in other bifurcations, often calcifications in the ostium, and even the ostial left main itself, which is different because of the more elastic fibers extending from the aorta into the ostial part of the left main that can make recoil a problem. And the angulation, I know you discussed that earlier, but often in the left main we have this very wide T-shaped angulation, and the effects that that can have on the stents may be causing stent fractures and also difficulty in delivering material. So again, when we talk about the left main, I lost my little. We have to say, do we have evidence to treat the left main? And certainly, it has been shown over long periods of follow-up that in syntax score that are low and intermediate, that left main PCI performs very well. But it comes down to the different types of disease we see in left main. So I'm just going to base my talk a little bit about 2 very different cases. One in a 56-year-old male where we have unstable angina. So we can see here a very clearly a 1-0-0 bifurcation with large vessels, wide bifurcation angle, not so calcified, but certainly involving up to the ostium, remembering that we're going to have to treat the ostium in this case. And then entirely on the other end of the spectrum, we have severely calcified disease with long segments of disease in both the proximal main, distal main, and the side branch, how these are very different bifurcations, and need to be treated in different ways. So when it comes to, this is just syntax data following out after one stent versus two stent technique. So that, in provisional strategy, less MACE in terms of a one stent technique than in terms of a two stent strategy. And again, here in Excel, where they showed again that there was lower rates of death, MI, or stroke when there was a provisional strategy instead of two stents. But the idea is to simplify the procedure, but not to oversimplify it either. Because certainly, if two stents are required, if you should use two stents. So the overall provisional the stepwise provisional strategy of one stent if you can, but certainly if it's required, two stents will perform better over follow-up. And this is some data from the 3-year follow-up of DK Crush. But again, we've always had the same questions about DK Crush in terms of how the trial was performed, and certainly with a lack of maybe respect for the provisional approach, where there was no evaluation nor any guidelines given in terms of how the provisional approach should be performed in left main stenting. And also, again, as we've mentioned, one stent if you can, two stents if necessary. And we know that the longer the disease of stent is in the side branch, the more likely we're going to need a second stent. So certainly these were cases where there was much longer segment of disease in the side branch, up to 15 or 20 millimeters of disease. More recently, we have EBC main again, and overall EBC main, which is a randomization of true bifurcations, true bifurcation left main lesions of a side branch versus a no side branch philosophy for provisional stepwise stenting. And just to take home message for me very much was that in the provisional strategy, only 20% of patients needed a second stent. So certainly one stent if you can, but two stent if it's necessary. And those patients who had a stepwise provisional approach had lower rates of death, MI, and revascularization. So what is the strategy? So it comes down to what is the risk of side branch occlusion? And as we've mentioned, that because of the large area, the huge amount of myocardium that's distended by the left main, the risk of side branch occlusion becomes extremely important, and it's a very pertinent question. So in terms of low risk of side branch occlusions, where we have, where we feel from the angiographic analysis that the risk of losing the side branch is low, a provisional T, tap or culotte if a second stent is needed. And if we have a high risk of occlusion, we need to secure the side branch first. So using DK Crush, or of course looking at the provisional approach using an inverted T tap or an inverted culotte technique. So if we go back to our first case again here, left main stenting mandates 2 wires, and obviously, significant trifurcation 3 wires. I think it's important as well to think about the size of the guide that we use for these interventions, because if we're going to be using balloons that are more than 3-5 millimeters, to be comfortable for the procedure, a 7 French is really going to be required. So when we look at this, we clearly can see what the diameters of the mother and daughter branch are. We have a good idea, but how do we know how big the left main needs to be? And we've already mentioned in terms of Murray's law. So with the 2 that we have, add the diameter of both and multiply by 0.678, which will give us an idea as to what the diameter we're going to need to achieve for the proximal part of the vessel is. So again, when it comes to choosing the vessel, the size of the stent, we size it to the distal reference, and we're careful not to oversize it, because we know that this is going to be a risk for carina shift and side branch compromise. very important when we are doing left main stenting. I think when you analyze the images beforehand, that we want to have a very clear idea in our heads of what the sizes and what the diameters are going to be, because that really influences the size, the choice of the stent. Different stent platforms and different stents have different maximal expansion capacities, and we need to know that particularly where that changes in the stent platform between medium-sized vessels and large-sized vessels in terms of selecting the correct size for the distal main stem. Sometimes we may need to choose a stent. For example, if the distal main is a 3.0 vessel, but we feel like we need we need a larger stent, a 3.5 stent, to be able to achieve the proximal main vessel diameter, we can choose the larger stent and deploy it at lower pressure, so that we have the capacity to get to expand the proximal part of the stent appropriately to the ostial or proximal part of the left main. So I think it's very important, the analysis of the images beforehand, and have a clear idea of the type of the stent that we're going to use, and we know our stents and we know the stent platforms, and we know exactly where the transit, what stent we're going to need, and that's going to and the stent and the size of stent that's going to be required to be able to optimally oppose the stent in the proximal part of the bifurcation. So again, when it comes to the left main, it's very important to find the view that works for us, and particularly when we're positioning the stent and we need to cover the ostium. So here you clearly see in this case that we need to cover the ostium, and AP cranial with some LAO can be a very good image to try and show us exactly where the ostium is. So sometimes we will need to, manipulate, use multiple angles, but an AP cranial with some LAO is often very useful to find that image where we can see where the left main meets the aorta, and not to have too much of the stent hanging out into the aorta, because when we do this, we always have a risk of a longitudinal compression where we have an interaction between the guide and the stent itself. And if we have this, we know that we have poorer outcomes if we have significant longitudinal compression or deformation of the stent that leads to increased MACE rates. So it's very important that we can clearly see the end of the stent, and that we pull back the guide with our left hand to minimize as much as possible any interaction between the guide and the stent, because it's at this point that longitudinal compression becomes an issue. When we have the jailed wire in position, it acts as an anchor and pulls the guiding in towards the stent and causes the longitudinal compression. So keeping our eyes always on the stent and controlling it with controlling the guide position with the left hand, particularly when we're removing balloons or doing wire exchange, it's really important to avoid this problem. So the pot is critical, and as we mentioned in the fractal laws, that the bigger the vessels are, the greater the difference in diameters between the distal and the proximal left main. And here, choosing a balloon that's appropriately sized, so we can, from our case that we saw, we can calculate the diameter that's going to be required for the pot balloon based on the circumflex and LAD diameters. And again, to find that view where we can clearly see the carina, to make sure that we advance the balloon just at the level of the carina and perform the pot. And it can be very important, it can take a while to find that view where the bifurcation is open. Often it'll be in a caudal view or in a spider view, where we can clearly see the separation of the wires and position our balloon marker at the level of the carina. And always remember to use stent enhancement techniques as well, which would be very useful to clearly see the stent outline if that's available in your cath lab, because it can also be very useful in the positioning. And it's not only at the level of the carina, we have to perform the pot right out to the level of the ostium, and make sure that we perform the pot all the whole length of the proximal left main. And pot, we have now evidence for the pot. It took a while to come, but showing that in bifurcation, that if we do not perform this pot, that the cumulative rates of MACE are increased after the procedure. So not just acutely, but out to a year after the procedure. And Again, also so again showing that pot versus no pot, higher levels of higher rates of instant restenosis. So not only MACE but restenosis. So we see that the pot has the effect of opposing the proximal stent to the vessel wall, but also has the effects of it favorizes it removes the struts away from the side branch ostium, and also it makes the wire recrossing more favorable by getting this strut out of the way and allowing us to rewire into the side branch. So we routinely use a third wire in left main stenting. So that's to secure the main branch. Always the main branch is always the most important, and we perform the main branch stenting, the pot, and then take a third wire so that we always know that the wire, in this case the LAD, that it's within the stent, that it hasn't passed under a stent strut, always securing and taking care of the main branch. Again, finding the view that works for us, where we can clearly see the bifurcation, and in this very wide angle bifurcation, making sure that the tip on the wire is appropriate, because here we see we need a very large angle on the wire to be able to make this bifurcation. If we have a 2 millimeter tip on this wire, it's going to be very difficult when we pull back the wire to try and engage that side branch. So making an appropriate shape on the wire, trying to pass the wire into the main branch in a loop if we can get it to do that, because it reduces the chance that you're under a stent strut, and then to very carefully pull back the wire in a very controlled manner, using the torquer to orient the tip towards the side branch, and using the left hand to slowly pull it back until we see the tip drop into the side branch. And then we can be sure that we've pulled it back cell by cell, the idea that we've entered the side branch most distally, which we're always targeting the distal strut to try and get into the side branch. Certainly, imaging, intracoronary imaging, can be is very useful. Is probably the main tool to exactly tell you what cell you've crossed into. But the poor man's OCT can be used with just here using the radiopaque part of the wire, and we can see here that the wire just before it crossed, that we've crossed more distally to where the wire is jailed. So it's a good indicator that we are in the more distal strut. And I mean, certainly kissing. I mean, we perform almost routinely kissing balloons for left main interventions, short balloons, long inflations, generally side branch first. But the most important for me is that the inflation is at the same time, because it's when the balloons are inflated that they will reposition the corona. Generally, as I've said, if you're going to be using more than 3.5 millimeter balloons, you're going to be more comfortable in a 7 French guide. Kissing is important as well because it clears any struts away from the side branch, opening access into the side branch, maybe not for today, but maybe further down the line. If your patient needs a further intervention, you'll be glad that you've done it. And also those struts that are sometimes across the ostium can act as bridges for neoatherogenesis, and can act as little bridges for where you get proliferation, and can act as a nidus for just stenosis formation at the ostium. So certainly the basic principles of evaluating the side branch for flow, evidence of any residual stenosis, and at that stage then take a decision if anything further needs to be done. So it comes back always to a stepwise provisional approach, where we perform the critical steps of the procedure, choosing the stent size, performing the pot, wire exchange and kissing, and then evaluating whether further intervention or not is going to be needed on the side branch. And I think we'll all agree that in this case that there isn't any further intervention going to be needed for the circumflex. So if we go back to a completely different case here, certainly not at all the same thing, far more complex in terms of calcification, length of disease, and what we're dealing with. Certainly, a 2-stent upfront strategy could certainly be envisaged in this type of case. so important to prepare the vessels beforehand, that, you know, particularly the main branch, that it's pre-dilated, and that, you know, in very calcified left main, that any other techniques that could be required, including lithotripsy, which I think is very interesting in bifurcations, because it allows us to keep the access to the circumflex with a second wire, are performed before the stent is implanted, because we're certainly far more limited once the stent is in place and what we can do to deal with an area of stent that's underexpanded. So I think it's very important to have tested, or should I say, tested the lesions beforehand with non-compliant balloons to make sure that we see that the lesion has been pre-dilated adequately, so we don't see any area of wasting on the balloons. So certainly, so that could potentially cause a problem for expansion of the stent afterwards. So this is, you know, a two-stent strategy, again, with main branch stenting towards the LAD, a pot. And I mean, certainly we know that we're going to need a second stent in this case, and using a tap technique in this case, carefully positioning the marker of the stent just inside the main branch stent to try and limit the amount of neocorina that's created, which is obviously any two stent techniques will be finished with a kissing and a final pot. So intracoronary imaging is certainly important in certain cases, particularly in early experience with left main. It comes from the calibration of our eyes and what what we see. Is extremely useful at the beginning in terms of the diameters that we're dealing with when it comes to the left main. It's particularly useful in two-stent techniques. IVUS and OCT can both be used and have their strengths and weaknesses, and particularly for if it's the ostium of the left main that we're trying to assess. OCT can be used, but certainly IVUS is a lot easier to control in terms of actually being able to visualize the ostium of the left main. It can be sometimes difficult with OCT. I think the impact of experience as well is very important when it comes to high volume and low volume operators, and it's a very good, I think the next data that I'm going to show you, it's an argument for having being accompanied, particularly in the early experiences with left main intervention. So, you know, higher volume operators have lower rates of MACE. I think that when we're starting off, it's very good to have an experienced eye on the procedure, and certainly to discuss the case beforehand in terms of the choice of material and what we're going to need to do to have the best outcome for the patient. Again, it's all showing the same thing, really, that in impacts of experience over quartiles, that, you know, with the experience, as we look over, you know, a long period of career from, you know, the early days of you know, early 2 to 5 years and over, you know, 10 years of experience, that certainly experience is important, and particularly when it comes to left main interventions. So to kind of summarize all of that, I think left main is something that we have evidence to treat left main. I think we should try and keep the procedure simple, but not too simple. We all need to have a two-stent technique that we're very comfortable to use. A stepwise provisional approach allows us to, if required, to transfer very seamlessly into a two-stent technique using a T, a tap, or a culotte procedure if required. And I strongly encourage at the beginning of anybody's career, when they start using performing left main interventions, intracoronary imaging is particularly very important at the beginning in terms of how we calibrate our eyes to the diameters that are going to be needed, and to always discuss the case with a senior or more high volume operator, because it can be invaluable in terms of how they see the procedure, and ultimately how the procedure is going to be performed, and this will all impact the long-term outcomes for the patient. Thank you.
Thank you, Dr. Antoinette, for the nice cases and demonstration. You know, the first question that comes into my mind, whenever we are doing left main intervention, there's always high risk of hemodynamic instability, which really makes the case very difficult. What do you think about hemodynamic support like Mbella or any other device?
I think, well, if you saw the second case, there was a balloon pump was used in the second case. That was an elderly lady with reduced LV fraction, and the right was occluded. So, I mean, in certain cases, I think if it comes down to, if you have patients, I think for routine, no, you don't need to use support. Often the impella itself can create more complications than it actually solves, it's sometimes I'm often astounded at how well sometimes patients tolerate prolonged kissing balloon inflations and POT, and they don't budge. I think that certainly if you have patients who have poor LV function and maybe have the right coronary arteries occluded, certainly thinking about maybe even a balloon pump support in that case can be, it can be a help. But sometimes it's more for us rather than for the patient, because it can be very, as I said, it's often astounding how well they actually tolerate the hemodynamic impact of the intervention. I mean, we need to perform the kissing balloons and we need to perform the POT for at least 15 seconds. We try and perform the POT with an adequately sized balloon for a minimum of 15 seconds. And sometimes if you see the patient that the pressure starts to shoot, you may need to work a little bit faster. But I think that, if you have good LV function, even if, I don't think we need to think about using support. It's in very select cases where we have fragile patients with, symptomatic heart failure and poor LVs.
So many times we are faced with questions. I'm trying to stent the left main, then I miss the ostium. What shall I do? Shall I put another stent, leave it? And what do I expect? What will be the outcome?
Yeah, I mean, I think it depends if the ostium is involved as well, because sometimes we see that it's more the distal part of the left main that's involved, and we may not necessarily need to cover the ostium in every single case, so, if there's a significant, I think that we tend to kind of cover back to the ostium, but sometimes you see that it's very clearly the plaque is in the distal part of the left main, just around the level of the bifurcation. And if we don't come out to the ostium in that case, is it a big problem? No, I don't think so. But certainly if there's osteal involvement and we've missed it, we need to go back with a second stent because you have to treat the plaque. We're going to have a certain amount of stent overlap there, but, coming back with an appropriately sized POT balloon, making sure that we have, good expansion. I think, if we miss the ostium, if there's plaque there, you have to go back and treat it.
What I understood at the end of your presentation is that with the experience, you know how to size accurately the left main and how to put with the appropriate balloon, and probably you don't need IVUS in most cases.
Yeah, true? I think I think it's with experience. I mean, I think it's very useful at the beginning in terms of how we see the left main and how big and how, what the actual diameters are. In a way, we can kind of calibrate our eyes to the IVUS or to the OCT findings. But after a certain time, we develop sort of a, we have not IVUS eyes, obviously you don't never have IVUS eyes, but certainly you have a much better feeling as to what the actual diameters are that you're dealing with. And, unless, I think that you can do the procedures without imaging, but I mean, that's with experience and also with the experience of your colleagues as well, who will, often, help guide you in terms of what the diameters are. And I think in those cases, then in cases of maybe if you have any unexpected findings or problems, imaging should always be the first thing to go back to try and understand exactly what's happened and then problem solve.
Muhammad, any question?
No. Not really.
No, I'm fine, thank you.
I'm fine also.
Probably we can move to the next presenter. Thank you.
Thank you very much, all. I'm going to introduce Dr. Thomas Hovas from the Cardiovascular Institute of Paris, SAD. He's going to share with us two interesting cases. Dr. Thomas.
Hello. So it's my pleasure to share with you two cases of our center. I think you can see my screen now. So let's go, and we start with 85 years old patient, which is still active. He has de novo angina. He has on the stress MRI anterior ischemia quite large of 5 segments, but also inferolateral ischemia for 3 segments. This patient have hypertension, dyslipidemia, and he has a moderate alteration of the renal function with creatinine clearance around 50. So you can see the angio now, which is a little bit low, I'm sorry. So there is a disease of a marginal branch, which is quite small. We are going to see the cranial view now, and on the cranial view, you can see quite long disease of the mid-LAD involving the first diagonal, which is a huge diagonal, and this diagonal present severe disease also on the ostium, and we can see that the angulation on the axis of the diagonal will not be so easy. So we can switch to another view, which shows us a tight lesion of the mid-LAD, and the spider view with nothing much on the left main, disease of the marginal we saw before. On the right, as you can see, present chronic short occlusion on its proximal part. So the syntax scores was calculated, and this patient, due to age mainly, was referred for a PCI of the bifurcation LAD diagonal, which is a Medina 011 lesion, and was planned for a CTO later. So we can see now the lesion we are going to treat. And you can see there is no tight lesion on the proximal part of the LAD, and a long lesion of the more than 4 millimeters on the ostium of the diagonal, and a long lesion of the mid-LAD. So as we saw before with my colleagues, we are in a case of high risk of side branch occlusion if we start by stenting the LAD in front of the diagonal. So we are going to secure the diagonal first by stenting it. And we can choose between DCA crush or main branch to side branch stenting, which can be inverted T, inverted tap, or inverted culotte. So in this case, so the angulation of the diagonals is almost 90 degrees, and that means that the DCA crush will not be a very good option, because the protrusion of the stent in the LAD will be perpendicular to the side branch, and when we will perform your crush, you will just make a longitudinal compression of the stent in the LAD. So the good strategy was choosing between the 3 strategy of the bottom, inverted T, inverted tap, or inverted culotte, and we choose to perform an inverted T or tap. We'll see what will be the result. So the first part, as every bifurcation, is to wire the 2 branches. Then on this case, we perform for sure a predilatation of the diagonal with a small balloon. The 2 wires are workhorse wire run through in this case. Then we advance our stents. You can see that we cover all the lesion of the diagonal, and also we pay attention to have enough length in the proximal LAD to be sure that we can do a pot. So that means you have to have you need at least 8 millimeters, because the shorter balloon we have our 8 millimeters balloon, so we need 8 millimeters in the proximal LAD. So we release the stent, waiting 30 seconds to have a good apposition in the distal part, and then we will perform. So it's a 2.5 stent, and you can see now a 3.0 balloon performing the pot. So to a very small and quick comment, I think many people are reluctant to perform the pot because of the fear to gel the wire and to have to problems to remove the wire. And it's very important to say that even with a good pot, a strong pot, it's extremely rare to have a wire which you can't remove. So you have to avoid removing the wire bumpy movement. So you have to remove the wire smoothly, but you can go with a quite strong force backward and pay attention to the catheter guide, which going to advance in the left main in most of the case. So the pot is done. So you see there is a pot up to the carena, and you have to cover all the lengths of the proximal part of the stent. So that's very important to do a second pot, like you see now, to pot the whole length of the stent in the proximal main branch. Now we are going to put another wire in the LAD, and you can see in this case it's quite hard to choose between a proximal and distal part, distal strut, but we always try to go in the distal strut. But when there is a tight lesion at this level, it's not easy to choose between different cells. But still, we try, as you can see here, to be as distal as possible. So then we performed predilatation of the LAD with a small balloon, and then we advance the stent, and that's very helpful to have a balloon in the diagonal. It will help you to position the stent T or tap as you want. And if there is a small protrusion, there will be not a problem to perform the kissing just after, and to avoid the difficulties to advance a balloon in the diagonal. So you can also, just before releasing the stent, inflate in the diagonal to see exactly the position. And you can see we are looking for T position in this case. So we release the stent, and after you use the two balloon, kissing balloon inflation, and then a pot again, which is not mandatory, but it's better to do a final pot when possible. And you can see the final result, which is nice. The second case is a left main case, and it's a 80 years old patient with distal left main disease. As you will see, he has also de novo angina, he has dyslipidemia, he has altered ejection fraction with 35%. Also, the creatinine clearance is relatively low at 43. And on the angio, you can see a disease left main, which seems disease all along, proximally and distally. Nothing much on the mid and distal LAD. You can see that the proximal part of the LAD, the ostium of the LAD, seems a little bit diseased. And you can see this view is very interesting because there is a very high marginal, and we can see the disease of the ostium of the LAD, which seem significant, and nothing much on the proximal part of the circ. And the right present no significant lesion. So you can see this left main now. Disease on the proximal and distal part of the left main, disease on the proximal part of the LAD, and nothing much on the circ, but there is a high bifurcation on the circ. So in this case, the plan was to avoid to put a stent in the circumflex or marginal branch, so to perform a one stent strategy, because there is no significant lesion on the circumflex. And we thought that the one stent left main 2 LAD could solve the problem without stenting the circ. And you see, if you need to stent the circ, or if you plan to do a 2-stent strategy in this case, you don't have 8 millimeters on the proximal part of the circ, so you will have to face a complex situation, something which like a trifurcation, or at least a very complex angioplasty. So, as Antoinette said, we tried to stay as simple as possible. So you can see, if we look the fractal law and measure the different vessels, you can see that the left main is evaluated to 4.4 millimeters of diameter. So we start with extra backup 375. We are in 6 French. It depends in the cath lab, sometimes 6 French, sometimes 7 French. I think it's not a problem to, and it's maybe a good advice for big vessel, for when you start to treat left main, to go radial for sure with 7 French. It goes very well, and it's quite helpful to have a stronger support and to have a less friction with your balloon. So the wire, the run-through wire in the LAD, as you can see here. Run-through wire in the marginal, and we start with a predilatation with a non-compliant 3.0 balloon at 18 atmospheres. Then we will advance the stent. So as you said before, if you want to avoid to miss the ostium of the left main, the better projection to put the stent, quite the only projection to put a stent, and to be sure to cover all the left main is a cranial view like this. And you can see that we cover a first little diagonal, which seems not big, with no disease. So we are confident not to lose it, and we decided not to protect this branch. So we put an Onyx 3026 according to the distal size of the LAD. So this is another view to see the ostium, and we inflate 12 atmosphere, 18 atmospheres, sorry, and 12 and 18 atmosphere. Then you can see the result after the stent, and we will perform a pot with a 4.5 balloon according to the measurement we done before at 14 atmosphere. So the result of the pot is like this. And now you can see it's very interesting, this maneuver. So a wire advance in the LED, a third wire. So as Antoinette said, also you want to secure the main branch, and you let all way during all along the procedure the main wire in the LED. So you advance the third wire, you go in the LED, and then you turn toward the circle, you remove a little bit the wire and try to make it fall in the distal strut. Then we performed kissing balloon. So you see the balloon in the circle is before the bifurcation with circle and marginal. And then you can see the result after the kissing, which looks like quite nice. And in most of the case, for the left main, it's also good to perform last pot, as you can see here, to avoid stent deformation, an oval stent deformation due to the kissing. And you can see here the final result of this case, which was quite quick, with 21 minutes of fluoro time, 138 cc of contrast, and a short hospital stay for this patient. So to conclude, I will say, like for all bifurcation lesion, you have to identify the difficulty and the risk. You have to wire both branches, and it's always to wire a branch and say, okay, it was not worth it, it was not necessary, but I did it, that to forget to wire a branch and lose it. So always wire both branches of your bifurcation, plan a strategy, use a provisional side branch treatment or stenting in most of the case, because it's the simplest way to treat bifurcation. And you can adapt your strategy step by step. You have to limit the number of stents. When it's possible, try to use only one stent on the bifurcation. And you have to restore the functional anatomy with a pot. If something is not clear, it's really helpful to use intracoronary imaging. And you have to share expertise, as we are all doing just right now. For left main bifurcation, know the characteristic of the stent that you are using. If you need to be sure that the stent will be you can expand the stent at the right size of the left main. So if you use a small stent for the distal part, be sure that the stent is capable of a good expansion in the left main. If we discussed that just before with Antoinette, if there is a very fragile patient with poor LV function, you can discuss to use a hemodynamic support. On the procedure with the kissing, to be sure that both big branch LED and circumflex are open. The stent position is sometimes not enough, so you have to be sure that the pot is good enough. So the pot is really, I think we all say that in our presentation, and don't be afraid to do so. There will be no problem with the gel wire. Thank you very much for your attention, and I'm ready for all the questions you want to ask. Thank you.
Thank you very much. Hello.
Yes, I'm listening.
Thank you very much, Dr. Hovest, for interesting cases. Seems that the first case, the approach was different. So you start stenting it looks like more of a mini clot, isn't it? The first case.
Not exactly. I think you can start like this when you do a culotte, but in the culotte, we will have put the second stent within the proximal LED.
Yeah.
And in this case, we try to do a T to keep one layer of stent everywhere and to avoid 2 layers of stents. But a culotte could have been performed for this case also. But I think the main point of the first case is to identify that the diagonal is very big, quite as big as the LAD, that the access of the diagonal is difficult, and the rewiring, if you stent the LAD, will be even more difficult. So the solution for this patient was to stent LAD toward diagonal as an inverted provisionality.
I have one question. When you have, for all actually, when you have a left main discrepancy between the left main and the LAD, and you have a distal left main lesion, and you overstretch the proximal part of the stent and the left main, is there any theoretical risk that the inhomogeneity of the drug exposed to the endothelium, so the chance of future restenosis, etc., is there?
Yeah, sure. It's a very interesting question, and I think it's really important to say that it's better to go with a bigger stent that you will inflate at very low pressure, not to harm the distal part of the vessel, but to be sure that you will be able to oppose it well on the left main. And you're perfectly right. If you choose a stent which is too small, it will not be capable. The deformation will be too strong, and you will not have a good efficiency of the stent on the left main. So that's very important to know the stent capability. It's really easy to find it on the internet. You just have to type stent expansion capacity, and you will have all the brand of the stents, of the different stents, all the size, and you can see what is the maximal diameter you can go up to. Okay.
Any comment? Any question?
What do you think when you have a distal left main with LAD and you plan to stent from LAD to left main? And there's major discrepancy in the size of using a platform stent in the LAD and then overlapping with a large one proximally.
Yeah, I think in this case you have, if there is a discrepancy which is really too important, I think the discrepancy, logically, the discrepancy between the left main and the circumflex will be not so important, because sometimes the fractal law it has to be respected. So in this case, the solution maybe is to stent left main circ and to put a second stent on the proximal LAD. So performing a T or a DCA crush. We don't like DCA crush at the ICPS, as you know, but you can do so. But I think that in most of the case, really, when there is, for example, a 4.5 left main and a 2.5 LAD or 3 LAD, it's not. You can go with a 5 within the LAD and inflate at 4 or 6 atmosphere, and you can see that the stent will not inflate really hard in the proximal LAD, and you will then correct and oppose well the stent with kissing or with a short balloon in the proximal LAD. So my opinion is really to use a bigger stent with a very low inflation at the beginning, if there is a huge discrepancy between the left main and the vessel you attempt to stent.
You know, we always have a discussion in a single stent strategy to kiss or not to kiss the side branch. We know in the early 2000s, there were several studies showing worse outcome if you kiss. And then later on, other studies showed that the outcome may be better when you open the strut to the left main. So what's your strategy and what do you think of that?
I think if you perform a good pot, you will at least open a little bit the stent towards the side branch. So if you do so, after we can discuss everything, it's less important. But if you do not do a pot and you do not do a kissing, I think the outcome will be worse. So at least do a pot, and then it is something between your feeling, your experience, the result on the side branch, and you can, if the territory is very large, and you see you have, for example, an intermediate lesion pre-existing distally on the side branch, you may think, okay, this lesion maybe it will evolve and become tight, and I have to go back there, so that better to keep the vessel open. If there is a good result without kissing, the branch is not so big, you are happy with the result at this point, you perform a pot, you say, okay, I can do it without kissing. So it's really case by case appreciation. I think but if you have generally, when you have a doubt, it's better to do a kissing. If you say, okay, really, I don't need a kissing, it's okay. You say, maybe I should do it. Generally, the answer is you should do it.
Interesting. Any questions? Any comments?
You know, there's a question from the audience. It says, what do you think about more support wire into side branch for difficult angles more than 70 degrees, like whisper wire, for example? It could be changed. It could change the angle to less than 70.
It's an interesting question. I think the best is to keep your workhorse wire all along. If you have difficulties to recross the strut, my personal strategy is to go first with a Fielder FC, then a Fielder XT, and then use a dedicated microcatheter to help me to recross the stent. And I think when you have the more frequent problem we have is to be unable to recross the stent with a balloon. So that's why we need quite a strong support with our guiding catheter, and extra backup is important for left main, and 7 French could also be important. And I think if you have difficulties with a new balloon, which was not used before in the procedure, you must be very careful to think that your wire was not under a strut, or there is a twist between the wire, because generally that's the problem. It's not the support of the wire. If the wire, if you cross, maybe the pot was not good enough, was not up to the carina, because and don't hesitate to redo a pot at this point, maybe with a bigger balloon, and be sure to be at the carina, and it will start to opening the struts towards the side branch.
You know, does the stent design make a difference in your choice? For example, we know for example, Synergy stent, the stent is away from the dot, while Xience, it's almost at the dot. So when you try to nail the ostium, it will be more difficult in Synergy or Medtronic than in Xience. Do you face this issue?
Not really. I think we used different type of DES. I don't have in my personal experience, but we can ask Antoinette or Thierry what they think about it, if they feel that there is a big difference between Xience or Onyx or Synergy. We actually try the Megatron stent, which is a little bit dedicated for the left main, but we have no we have no conclusion to give at this point. But I think all the last generation DES like Onyx, Xience, and Synergy are good for left main.
And I think as well, you can see it. You can see the gap sometimes between where the stent starts and where the marker is. So you can, if you have stent enhancement software, it's really good because you have a much better idea of where the stent starts. And sometimes there is a good gap between the markers. So don't trust the marker, trust the stent that's on it. And once you're used to using certain brands and types of stents, you know that. So you correct then for that for that little gap between the marker and the beginning of the stent frame. So just use the stent boost or whatever, or even just a graphy collimation and just do simple graphy, and you'll see it a little bit better.
Yeah, I think this point from Antoinette is very important. For the first case of Thomas, we have seen that the marker was a little bit inside of the balloon when the positioning was done. But in fact, it was just a marker of the balloon, not the stent. And if you do a stent enhancement, in this case, you can see clearly that we have not done a mini kiss, but we have really done a T stenting. So it's very important to have this information in mind, that the marker of the balloon is not the stent is not at the level of the marker of the balloon, and it depends on the company. So Xience is not the same as Onyx or Terumo stents. The other thing that we have not discussed is a wire wrap. I think wire wrap when treating bifurcation lesions is really our enemy. So that's why it's very important when we put the second wire in place to avoid twisting the wire without a torquer, because when you twist, you make a wire wrap, and then you have a lot of difficulties with the balloon, with the keys, with everything. So that's why we strongly recommend to use, at least for the second wire, a torquer, to be sure that you are not rotating more than the wrist rotation, because then you make a wire wrap. And this is a big issue when doing bifurcation lesions.
I always say there are two types of interventionists. Those who are planners, they look, study, decide, and then they plan and proceed with intervention. And the others, they have reflex, who are adventurers. They just see a lesion and they jump into it and they start intervening, and then they try to deal with whatever issue comes. I think if you are a planner, you always win. If you are an adventurer, you may lose.
Good point.
Thank you.
Just one question. If when you do the provisional stenting, and then you compromise the side branch, and you get the wire with difficulty through the strut, and you cannot get even a small balloon, which is 1 millimeter. Anybody has used the microcatheter just to pave the way for you before using the smaller balloon? Any of the panelists?
Thomas?
So when your question is when you lose the side branch after stenting, or after
yeah, you compromise the flow in the side branch. When you try, your strategy was the provisional stenting,
yeah,
and then you compromise the side branch. Then you go through the struts of the main branch to the side branch,
yeah,
but you cannot get a balloon in, even a small balloon, which is 1 millimeter. So anybody had used a microcatheter through the wire which is through the strut, to pave the way for you to use a small balloon?
Generally, if it's a new small balloon, a very small balloon, the profile is generally better than a micro catheter. So I'm not sure that the micro catheter will go in if the balloon is not going through the strut. My advice at this point, if you do a repot or a pot, if you have not done the pot up to the carena, it will really help you to start to open the strut, and it will help you. It will help the balloon to cross. And if not, you can advance guiding catheter extension in the left main, and to increase more your support and to cross the balloon. If the balloon is really blocked at the level of the stent, or the other option is thinking that you are in a proximal strut and try to take another wire and to aim a more distal strut. But at this point, as you say, if the flow is compromised in the side branch, that means that you have a really tight stenosis at the ostium, and generally you don't have a choice between one strut or another. But my advice at this point would be to redo a big pot, and then if it's not necessary, with your better balloon, to advance a cat extension. And also you can advance a balloon in the main branch and try to make an anchoring to increase the support of the extra backup and to help you to cross the strut.
Yeah. But I think that the first step is to redo a pot, as you said, and try another strut, because usually when you are not able to cross with a 1.0 balloon, it's because there is a problem of struts or which are not expanded. Of course, if you have already done that, you can go to other techniques. But the first is repot with a good size at the right level.
Interesting. Very good. Dr. Kurdi, you want to conclude?
I personally enjoyed the presentations and the discussion. It's a great, I think it's a great session. We have discussed the bifurcation. Dr. Thierry, in the beginning, he actually went through a very nice presentation and summary with a great outline of the concept of approach to bifurcation. And then we seen in the second presentation a very nice, what I call tricks or tools trying to cross the side branch, and how could you do that? And this is what we continue to discuss. And it's going to be always a challenge that we learn some new tricks as we go through, but it really was a nice presentation. I think Dr. Antoinette showed us why left main is different, and how tackling different left main with different anatomy. And that was a really great presentation. So we learned a lot, and we've seen a very interesting cases by the last presentation by Dr. Thomas, and really a very complex, interesting, sometimes you think it's a trifurcation, but then if you think about it for a while, you think, no, let's make it simple. Let's try to make it simple. I want to get out of here, and I want to be as much as possible evidence-based, doing what I think the good for the patient for a short term and a long term. And I think in this presentation today, we've seen the wisdom of our operators, we've seen the experience, we've seen the knowledge, we've seen the skills, and I really enjoyed what I've seen tonight. And I thank you all for your time and your effort and sharing your knowledge. I thank the Gulf Interventional Society for giving us the opportunity to do such webinar, and Medtronic for supporting such events. I think this is a great webinar that I hope our audience enjoyed it as much as I enjoyed it. And I would like to thank you again, guys, from Paris, I hope you enjoy the rest of the night, and we hope that we will meet in person very soon. If there's no questions, I think we'll conclude the session, and thank you all.
Thank you.
Thank you.
Thank you very much.
Ahmad. It was a
Thank
pleasure
you.
for us to be with you and to share experience.
Thank you.
Thank you all. Thank you.